Good evening. Good evening. Can you hear me? No? Can you hear me now? You can't hear me? Because if you can't hear me, you wouldn't be able to hear Sami Timimi. You do hear me. Thank you. Okay, good evening. My name is Ayla Amir, and in my role as the Executive Director of AMI-Quebec, I'm happy to welcome you to the 2025 Mental Health Forum. This evening is the successor of the Low Beer Memorial Lecture, which had been an AMI's main annual event for 30 years. It was renamed the AMI-Quebec Annual Mental Health Forum a year ago, and like its predecessor, it is aimed at raising awareness and understanding of mental health and mental illness issues, related issues. The Department of Psychology at Concordia University and the Center for Clinical Research in Health have collaborated with us, with AMI-Quebec, on this annual event, and we are grateful for their ongoing interest and support. I assume that many of you are familiar with AMI-Quebec, so I would like to encourage you to sign up for our emails and visit our website often so you can stay up to date with our programs. Tonight, we are happy to welcome child and adolescent psychiatrist Dr. Sami Timimi, who will help us better understand how the current mental health ideology may compromise the health of our younger generation. Calling for radical shift where psychiatric diagnosis will no longer be used and the use of medications will dramatically decrease, Dr. Timimi's strong assertions may not be easy for everyone to hear. Moreover, Dr. Timimi calls for the promotion of a narrative that will help to rehabilitate emotions back into the sphere of the ordinary and/or understandable, rather than pathologizing and consequently medicalizing them. But as Dr. Timimi quoting, but as Dr. Timimi is quoting Alfie Kohn, the time to worry is when the idea is so widely shared that we no longer even notice it, when it is so deeply rooted that it feels to us like plain common sense. At the point where objections are not answered anymore because they are no longer even raised. We are not in control. We do not have the idea. It has us. This, I believe, may well be the case with our current approach to mental health challenges, where we are quick, often too quick, to pathologize experiences that in other cultures may be viewed as normal occurrences in the passage of life. Dr. Sami Timimi is a child and adolescent psychiatrist and psychotherapist. He has written 40 book chapters on subjects related to critical psychiatry, childhood, psychotherapy, depression, behavioral problems, and cross-cultural psychiatry. He authored 6 books, and his most recent book, Searching for Normal, often compelling arguments and leads to the conclusions that we need to seriously reflect on our current approach to mental health if we wish to spare our children and youth the many unwanted outcomes of this approach. Questions from the audience are welcome after Sami Timimi's presentations, and whether you are attending in person or online, you can send questions using your smartphones or computers. Visit amiquebec.org/forum, F-O-R-U-M, to submit your questions or email them to info@amiquebec.org. The questions will be forwarded to Dr. Timimi after the presentation and be integrated into discussion following the presentations. We will address as many questions as possible, but may not be able to address all of them. So I look forward to a stimulating and intriguing talk and would like to pass the baton to Dr. Timimi.
Thank you very much for that introduction, and thank you for inviting me and sharing with the audience a couple of my slides. For today's talk, I thought I would try and summarize some of the main themes that came out of my recent book. The idea for my recent book really came up from conversations that I was having with my adult children, and they were telling me about situations with their friends and friends of friends, and also with patients that I was seeing, with grandchildren that I have and their mother, what she was saying about the types of conversations that were happening at school gates and nursery pickups. And this was in the era just after we came out of lockdown from COVID. So we'd just been through a major psychosocial event. And there was a lot of pessimism around. There were a lot of conversations about how things felt broken, that our society wasn't functioning, that people were not in a position to feel that they could look forward to a positive future. There was a lot of dissatisfaction with jobs and a lot of insecurity about jobs and high rents and things like that. But at the same time, I was hearing about all these people getting these diagnoses. And even in the clinical life, what I was witnessing is that we'd just been through this great big psychosocial event which disrupted our lives in all sorts of ways. And yet when people were coming forward to our services and being seen, they were being categorized with these conditions, and it's as if this great big psychosocial event didn't happen. So there was this shift to seeing the problem even if it had been affected by what was going on in our society over those year or so when we had these great disruptions. It was being then turned into something that had become a disorder within the person that required some sort of within the person intervention. So all of these things that were going on, that on the one hand there was increasing distress and pessimism, and on the other hand there was this really quite tremendous increase in the numbers of people getting diagnoses and interventions. And then on top of that, something really started to take off, which is we started hearing about all these different celebrities and high-functioning people who are very successful, journalists, who started coming out and saying they have conditions like attention deficit hyperactivity disorder and autism, and yet these were some of the most successful people around. So there's something going on, and I felt it was time to try and explore these and try and understand what are the assumptions, the hidden assumptions that might be sitting behind this. So in the first half of my book, or maybe the first 2/3, I'm trying to unpack what are the assumptions that go missing. And then how did we get to a situation like the one that we've got to, where there is a spread of these ideas and this ideology that has very little basis in scientific evidence, yet it is being assumed that we're picking up on real conditions that science has somehow enlightened us to. So that's my little preamble to give you an idea of what I'm going to talk about. And like I say, it comes from this latest book where I'm trying to understand and explore these phenomena. I actually start the book with this quotation from the Italian philosopher who was imprisoned by Mussolini, and at the time he wrote all of these prison notes, and it was in the run-up to what eventually became the Second World War. And in Europe at the time, it was a time of great hardship, and there was this ongoing battle between the rise of communism on the one hand and the rise of fascism on the other. And so this is a very apt, I think, quotation, which in some ways is applicable to what's happening in our society at the moment. I think a lot of us do feel things are not working, something is changing, there's a lot of militarization going on around us. So the old world is dying, and the new world struggles to be born. Now is the time of monsters. One of the ways I tried to structure the book was to try and connect it back to clinical work. So a lot of the chapters start with a clinical case, and then I go into some theory, some evidence, and then I end the chapter with what happened to this clinical case. So the clinical cases are all anonymized, of course, but they are drawn from genuine encounters that have happened in my clinical life. So I'm going to give you a little taste of that by introducing you to somebody I'm calling Charlotte. And at the end of this presentation, I will tell you what happened to Charlotte. I'd been seeing Charlotte on and off for the last 2 years. She was now 17. Before my involvement, she'd been seen by our service and received several different therapeutic interventions since she was 13 years old. All sorts of strategies had been tried. I'd seen her on her own, with her mother, with her father, as her parents were separated, and even once with her boyfriend. We'd looked at her thoughts, discussed her traumas. We'd even tried medication, which she discontinued after initially feeling it was great, and then after a couple of months coming to the opposite conclusion. I'd spent a lot of time noticing her strengths, natural resilience, and I'd discussed with her with colleagues and brought their feedback to her. Over those 2 years, she'd have better periods, and then at some point would crash, take to her bed and withdraw for days, sometimes weeks. Periodically, she would have other experiences and behaviors, such as intrusive thoughts and images of her or others dying horrible deaths. Periods where her food intake was poor, and sometimes health anxieties, such as thinking she had a brain tumor. Now she was in another down period, and I was wondering what to say when she blurted out with an angry passion, "How can I get rid of this thing in my head?" So I shall come back to Charlotte later. There is little disagreement now on the picture that we have as far as mental health outcomes from the types of services that we are offering these days. So this is a very common type of conclusion that you're going to see from different books and papers and articles. Mental health is getting worse by multiple metrics. Trends are going in the wrong direction even as more people seek care. That's not true for cancer, it's not true for heart disease, it's not true for diabetes or almost any other area of medicine. So there's something about mental health care that seems to be an outlier. So despite this little progress in what we consider to be improvements as a result of the types of interventions we're offering, what counts as a mental disorder has been expanding, which means there are more and more people who are considered to have a mental disorder, and yet the types of services that they're likely to be offered do not have a good track record of suggesting that it's, at least at the population level, going to lead to significant improvements. So we see this pattern of rising rates of diagnosis across psychiatric presentations, but of course as a child and adolescent psychiatrist, the area I'm most interested in is what's happening with young people. So for example, taking some statistics from the UK, ADHD in children and adolescents has increased from about 0.5% in 2003 up to 5% in 2023. At the same time, ADHD in adults has found a tripling of rates between 2010 and 2020, and it carries on rising. Autism in children and adolescents, the early studies had just about, it was considered a very rare condition. Those who got the diagnosis tended to have moderate to severe learning difficulties. Indeed, in my first number of years of practice, I only came across a handful of children and young people who got a diagnosis of autism, and each of them had significant learning difficulties and were unlikely to be able to live independently as adults. But nowadays, we're up to about 3%, and there are some studies that are showing 5%. And it's rising. This is a meteoric rise in incidence, in prevalence over a very short period of time historically. The increase in adults getting an autism diagnosis has been particularly significant, and I'll come back to that in a little later. And at the same time, the amount of prescribing of psychotropic medications has also been increasing and increasing rapidly. And the SSRI, which are often referred to as the antidepressants, is a particularly worrying one because there's yet to be a single well-controlled and high-quality paper that has shown that in this age group, even in the short term, these types of antidepressant are significantly better at improving your mental state than a sugar pill. But they come with significant side effects. And there's a similar picture in Canada, increase in prevalence of anxiety, depression, and other mental health conditions, a tripling of anxiety disorders in particular amongst young women, a greater proportion of the population who are saying that they feel their mental health has deteriorated in the last number of years, and so on and so forth. And we've also had this new phenomena coming, for example, Matilda Bosley, who is a Melbourne-based journalist, wrote about her experience of getting a diagnosis of attention deficit hyperactivity disorder because of the types of videos she liked to watch on TikTok. And TikTok kept sending her videos of people who got a diagnosis of ADHD, and that got her wondering if she had a diagnosis of ADHD. She went and paid for an assessment, she got the diagnosis, and then wrote about how liberating it was and how she reinterpreted so many things in her life through this new lens. For example, she started talking, one of the examples she gives is that she used to think that the reason her flat was always untidy and she could never get round to tidying it up was because she was lazy. But now she understood it was because she didn't have enough dopamine in her brain. So all sorts of experiences get reinterpreted. And so there's this phenomena where social media is alerting people to an idea that they might have certain conditions. If you look at the rising rates of autism, and this is pre-COVID, it's gone a lot higher since then, you will see that it's been rising rapidly over the last couple of decades. But if you break that down, most of the rise is coming with adults who are getting the diagnosis, and most recently, the group of adults who are getting the diagnosis are more likely to be female. So something about the whole way we think about and understand a condition like autism has shifted from this very rare condition, predominantly in those with significant learning difficulties, to a much wider condition, and most recently to an idea, and I will come back to this idea, that there's something called masking, so that you don't even have to have observable symptoms. What has to happen is that you feel you have those symptoms, that you sense that, but you've become very good at masking those symptoms. And that enabled a lot more diagnoses to take place amongst women. In terms of outcomes, we see this picture, despite all of these rising levels of diagnoses, the picture in terms of outcomes isn't terribly encouraging, and I can go through a whole set of studies that demonstrate that when you look at this through randomized controlled trials, they have some evidence of improvement, but when you look at what happens in real life services, that doesn't seem to be translating. For example, the recovery rate from child and adolescent mental health in the UK, child and adolescent mental health services, we had imposed on us a new model of working that was imposed across CAMS services in England and Wales, and it was imposed in 2016. And this model is a treatment pathway model. So there are 9 different treatment pathways, like a treatment pathway for generalized anxiety, for depression, for ADHD, and so on. So there are these 9 treatment pathways. When they did the pilot studies in order to train people up to do the types of therapies that they said we should be offering, which were mainly like cognitive behavior and other individualized type therapies, their significant improvement rate in these pilot studies after 1 year was between 3% on some of the child-rated questionnaires, and 6% was the lowest on some of the parent-rated questionnaires, and the highest one was 33%. And the average was a recovery rate of 18%. Would you feel that that's the sort of service that you'd want to attend, or that you would have trust in? And we see review after review coming to a very similar conclusion. So a review of services in the UK that was published last year concluded that the mental health of children and young people is deteriorating. The prevalence of many mental disorders is increasing. Well-being is decreasing, and inequalities in mental health are widening for some groups. So this is now referred to, this is a well-known phenomenon. More and more people getting a diagnosis, outcomes not improving, if anything, they're getting worse. And this is now referred to as the treatment prevention paradox, because if our services were actually at a population level effective, we should not see an increasing prevalence. We should at least see some stabilization. But it seems the more services we have, the more mental health problems and diagnoses we seem to have. Here's another example. There's been the largest randomized controlled trial of CAMS services, that's child and adolescent mental health services, took place, and the results were published earlier this year. They basically randomized different child and adolescent psychiatry services within different areas into one group who were getting a thorough diagnostic workup, and the other group were just getting a less thorough one and putting on these treatment pathways. And they then followed them up for up to 12 months. And so this was a naturalistic study. These were people attending the services in their area and either getting this diagnostic workup or not. First of all, they found no difference whether you got this thorough diagnostic workup or you didn't. And in both groups, what they found was mental health difficulties continued to remain at a severe level over this period, with high levels of self-reported and parent-reported mental health symptoms, functional impairment, self-harm thoughts and behavior at 12 months follow-up. Another study that was published earlier this year was around universal mental health education programs. These have been going on for quite a while now, and schools have been implementing these mental health education programs, and the whole idea about helping young people develop their mental health awareness is destigmatization, and also the hope was that this would lead to a reduction in the number of people who were then experiencing mental health difficulties and who needed further intervention. The studies keep finding the same thing. So this was the Youth Aware of Mental Health. It was a large study of this type where they compared groups in schools. They gave classes in schools this mental health awareness intervention. So these are whole class interventions, and they compared it to classes that didn't have these interventions. And what they found was no overall statistically significant impact on young people's emotional difficulties at the short-term follow-up at 3 to 6 months, but an increase in emotional difficulties at the long-term follow-up of 9 to 12 months after intervention. In other words, those young people who are getting the mental health awareness intervention, education, were actually more likely to be experiencing emotional difficulties at 1 year follow-up. So it seemed programs like this may well be sensitizing young people to think about their experiences in diagnostic mental health terms. So all of this needs us, I think, to try and take a step back and think about what are the hidden assumptions. Maybe there's something about the way we're imagining and responding to what we consider to be mental health that we need to rethink. I've been doing exercises like this with all sorts of different groups for quite a few years now. Psychiatrists, psychotherapists, psychologists, teachers, lay people, just asking them the question, give me your best definition of what you think mental health is, and therefore what you think a mental disorder or a mental illness is. And of course, the one thing that all definitions have in common, and you might be trying to think of your own definition right now, is that they're subjective. What you can't do is escape empirical anchors. There's no empirical anchor to place it beyond the imagination, beyond your subjective definition. Take a look at the World Health Organization definition of mental health. A state of well-being that enables people to cope with the stresses of life, realize their abilities, learn well, work well, and contribute to their community. Well, how many subjective words are there in there? What the hell does a state of well-being look like? How would you know that this is well-being? What does it mean to cope? How do you know if you're coping? And what would you consider the stresses of life to be? What does it mean, for example, to contribute to your community? for all sorts of reasons, people may not be in a position to contribute to their community. Anybody who's preoccupied with survival, with paying the rent, keeping a roof over their head, or who've got some challenging physical disability, they may not be in a position to contribute to their community. Does that mean by definition they're mentally unwell, that they have a mental disorder? So you can see the problem here when the whole parameters, not just the boundaries, but all the parameters are subjective. This enables it to be stretched in all sorts of directions depending on how you define these particular facets. So here's the first assumption. We literally don't know what we're talking about when it comes to mental health. The problem is, we often act as if we do. So those sorts of questions are rarely raised when people are discussing mental health, mental disorder, when they're discussing it in the media, when they're discussing it in academic papers. So we act as if we do know what we're talking about, but actually we don't. And I think it should be necessary for us to be able to be honest that what we think about in terms of how we think about mental health is subjective. Let's take another thing that we need to unpack. We talk about psychiatric diagnosis, but do we understand or do we know what we mean by a diagnosis? So a diagnosis is a system of classification. There's lots of different systems of classification. Different systems of classification serve different functions. A diagnostic system of classification is classification by reference to a cause, in particular a proximal cause, an initial cause. So you can take your computer to an IT technician to run diagnostic tests to find out why your program isn't working. You can take your car to a mechanic and they might run diagnostic tests to try and understand what's wrong with your car. And in medicine, diagnosis refers to a proximal cause. If you fall and you've hurt your arm and there's a swelling and you can't turn your hand around because it hurts too much, you might go to an or you call it emergency room, that's what you call it here, is that right? We call it accident emergency. And they might do an x-ray and find that you have a fracture. You now have an explanation, and identify an initial cause as to why you are experiencing those experiences. You now have an empirical anchor. You now have the basis on which to define a case. And empirical anchors are quite important if you want to develop technical knowledge around, say, this type of fracture. You can now look for secondary causes. Maybe there are different types of bone problems that might make you more likely to have a fracture. You can look at different other things that might have. You can subclassify fractures. And you can also now monitor the effects of different treatments, because you know that a successful treatment, the bones will fuse again. They will no longer have a fracture in them. Similarly, if you take something like high blood sugar. So in diabetes, we don't define diabetes by describing the types of symptoms you might have. You don't say diabetes is going to the toilet a lot, feeling thirsty, and maybe feeling tired, because diabetes may not present like that. Other conditions may present like that, and it could even just be a kind of psychosomatic thing that's going on, particularly these days where everybody seems to walk around with a bottle of water and sipping away, and then of course they need to go to the loo. So you define diabetes by reference to high blood sugar. Now, there's all sorts of disagreements about the boundaries and when you should manage this using dietary approaches or medication and so on and so forth. But again, you have a starting point in which to classify a case, and that starting point is empirical. It's separate to the descriptions and it's separate to your imagination. And the thing about having that empirical starting point that enables defining a case is you can now develop a set of knowledges around this, which can include processes, types of techniques that appear to improve the likelihood of recovery or improvement in your symptoms. You can develop this kind of scientific knowledge framework. That doesn't mean that other things are ignored, like the social context, the relationship with the treating system, patient expectations, and so on. But they do become secondary in nature to the primary task. So the primary task in most of healthcare is to try and ascertain the correct diagnosis in order to deliver the correct treatment for that diagnosis. And that is the way we operate. It is the way we operate with ideas of diagnosis in psychiatry. So we think that when you have a diagnosis of depression, you have understood the cause of feeling sad and having a lot of guilty thoughts and negative thinking and so on. But actually, if you look at the criteria for a psychiatric diagnosis, apart from a few, like the dementias and certain types of learning difficulties, they are all descriptions. So, for example, if you ask what is attention deficit hyperactivity disorder, the only way you can answer that is by describing things. So it's the presence of poor attention, hyperactivity, and impulsivity. And we're back to this subjectivity that I was talking about. So you're already in the realm of subjective. There's no empirical anchor there. There's no starting point for creating that kind of diagnostic knowledge, scientific, technical knowledge base, because you have no empirical anchor. And another way that helps you realize that is to understand what happens if you start treating it, as we do, as if it's a diagnosis. So if you start saying, why is your child hyperactive and struggles with their attention? And if you're answering diagnostically, you would say, it's because they have ADHD. And that's what we tend to say. A legitimate question is, how do you know they have ADHD? I know they have ADHD because they have poor attention and hyperactivity. A description can't cause itself. This is what's philosophically known as a tautology, a circular thinking trap. And it's quite incredible, really, when we don't realize how widespread this circular thinking trap is in mental health ideology. It's a bit like saying the cause of the pain in my head is a headache. A description cannot cause itself. So there is another fundamental error going on there. And you can see that when you compare these two examples I've given. In diabetes, you have empirical anchors that are the definitions. In ADHD, they're just sets of behaviors that are being labeled as symptoms, and they all start with the word often. So often fidgets with hands or feet. What's a unit of fidget? How much movement do you have to measure a unit of fidget? Nobody does that. How many fidgets per second, per hour, whatever. So we have this problem where we treat these presentations as diagnoses, but they're not diagnoses. But we can go further. we can start interrogating other things that have assumptions to them. So what do we even mean by the word mental? My second language is Arabic. I have an Iraqi father and an English mother. And I've written a couple of papers in the past for the Arab Journal of Psychiatry where you have to provide an abstract in Arabic. So I got my father to help, because there isn't a direct word for mental in Arabic. But the most common word, there's a number of words that could be used. The most common word that is used is a word nafsiya. Now, nafsiya refers more to a kind of a soul self. And the word nafsiya has its roots in the word tanaffus. Tanaffus is to breathe. So there's a close connection between that sense of self and soul and breathing. You see that in a number of religions, actually. Whereas the roots of the word mental comes from the Latin mens. The Latin mens refers to thought, consciousness, and right thinking. And it reflects a shift in Western philosophy that happened particularly in the years after the Enlightenment, where rationality became very highly valued. And you see that kind of in there, in the way we think about mental health. And one of the things that seems to be prevalent in the way we think about mental health is a fear of emotions and a valorization of rationality and logic. And that's something that isn't so prevalent in, for example, the cultures that brought about the idea of nafsiya. So even the word mental is already betraying a framework for how we imagine what a problem in what we might consider to be a problem in our experience is rooted in and might look like. And we can keep asking these questions. For example, what do we mean by self? How do we find the self? And anthropologists have been looking at questions like this for a long time. And in general, they refer to tendencies in different cultures to focus on different aspects. So there's some cultures are much more focused on an individualized definition of the self. So these are the cultures where you sort of think about how to look after yourself, the importance of nurturing yourself, being kind to yourself, etc. Collectivist orientated cultures tend not to think in those manners. Another difference, for example, is in Arabic, I don't know the word or the phrase that equates to self-esteem. That is quite an individualist concept. There's words and phrases that might talk about confidence, but that's something slightly different to self-esteem. So, no culture is purely individualist or purely collectivist, but these are tendencies of what tends to be more likely to be focused on. So individualist cultures, which tends to be, Western cultures tend to be individualist cultures, they focus on control of emotions. They like to differentiate and classify different types of presentations. They often start with a sense of the person being primarily vulnerable. And as a value system, they tend to focus on rights and freedoms for the individual. Whereas collectivist-orientated senses of self tend to look at emotions in a much easier way. So emotions are something that to be experienced. They're not as interested in how you classify different types of people. So there's a much more of a sense of common humanity. They tend to start with an idea of humans being resilient, and the types of value systems that tend to be promoted are often around concepts of duty and responsibility. So all of that means that firstly we when it comes to mental health, we don't know what we're talking about. But secondly, what we call psychiatric diagnoses are not facts of nature, they are facts of culture. They are our own inventions. And we can see these changes in concepts that have happened. So I call this a mutation of constructs, because when your definitions are subjective, you can start changing what comes into an idea of something being problematic. So ADHD starts as a rare condition. It originally started being called something called hyperkinetic disorder, certainly in the UK. But in my first years of practice, never come across any child with this diagnosis. It was only in the mid-90s that the idea of ADHD started coming in from this side of the pond. And ADHD brings a slightly wider definition, not a slightly, quite a considerably wider definition than hyperkinetic disorder, because it now introduces the idea not just of how much you're moving, but also the idea of attention. So it includes a focus on attention levels. And the initial definitions excluded children with learning difficulties because it was assumed that was enough to explain why they might be more restless and fidgety. So we now have an expansion of the number of children. At this point, it's still considered developmental. By developmental, it was considered that most children would actually grow out of this as they grew older and went into adulthood. But by the 2010s, this concept was changing again, and the idea that it was lifelong, but in adulthood it presents in different ways. So it started shifting to less of an emphasis on hyperactivity and more of an emphasis on things like difficulty keeping time, being disorganized, and these were said to be the types of presentations that you would get in adulthood. So a shifting of the criteria. And then in the last number of years, the concept of masking comes along, and it's very much focused on this sense that you're not fitting in. And often, especially in this social media age, you imagine everybody else around you is able to fit in a way that you can't. If only they could see into each of our minds, because you'd realize that most of us have those experiences these days. This is what our society is like nowadays. And the important thing to make clear is that this mutation of constructs, this stretching this way and that way, has not occurred at any point following some significant scientific discovery, something that makes us aware that there's some identifiable characteristic difference or abnormality in the bodies or brains of people who get these diagnoses. So you don't have a blood test for ADHD. There's no microscope that can examine your thoughts and pick out the ADHD thoughts. Childhood depression is an example of a concept that moved the other way. Again, when I was training in the early to mid-1990s, childhood depression was thought to be something that children were not depression was thought to be something that children were not intellectually ready to experience. And so it was considered to be extremely rare, and only you might consider it usually following a history of severe trauma. But in the 80s and 90s, that started shifting. The success of Prozac as the first of the SSRI depression antidepressants, and by success I mean marketing success. There certainly wasn't a great success in the studies, it was a marketing success. So the idea that children probably experience the same things, it just presents differently in children, so the criteria were stretched to enable a concept used in adulthood to be imported into childhood. and the use of antidepressants in children started in the early 2000s, and it's carried on increasing. And again, at no point has there been any significant scientific discovery. And childhood depression, certainly in the UK, is probably the most common psychiatric diagnosis that young people get now. And one of the things that we're struggling to come to terms with in this era of imagining that we will get a scientific answer, that everything is kind of fixable in technical terms, is that whilst we can measure lots of things related to our environment, related to things that happen to us, and we could measure or try and get some idea about how we experience things, maybe through questionnaires or observations about how we behave, or the types of things that you might categorize in terms of your responses. The bit in the middle is a big black box, and we need to get used to the fact that this bit in the middle is not something that's going to be amenable to the same scientific frameworks that we use to understand the physiology behind a fracture in the bone. Because this is the part where meaning making happens. So this is the part that's inherently subjective. It's a bit like trying to work out the story for the film, for the series Breaking Bad, by looking at the electrical activity at the back of a TV. You're not going to get it with all these clever brain scans, and we're not getting it. So, this leads me to my third assumption that I think we need to question. In mental health, we create meaning rather than discovering it. When you apply to an experience and say, this experience that you're having is depression, you have created a framework of meaning that interprets how you feel as a symptom, as opposed to, say, a meaningful response, or it's something that many people go through, or something that's maybe a sign of how deep you are. There are a myriad different possible frameworks for interpreting how you feel. But the framework we choose to interpret our feelings, our behavior, have consequences. And this is the bit in mental health care that we need to think about more carefully, because the framework we choose to interpret people's experiences through have profound effects on how they then experience their experiences. So what we have is we have models, different ways of making sense, but the models we have all have potential consequences. And the consequences of going down the route of talking and responding in terms of your experiences and your behaviors being signs of psychiatric disorders is potentially quite profound. So what we've seen is more and more young people, in particular, identifying with the idea that their experience might be pointing towards the possibility that they're experiencing a psychiatric disorder. So this is a survey in 2019 before COVID. 68% of young people, this is a survey of 1,000 young people in the UK, 68% of them thought they had or have had a mental health problem, and that 62% of them thought it was destigmatization campaigns that had made them aware and helped them identify it. And so we see these trends. So a report from the Centre for Social Justice earlier this year, 1 in 5 people report receiving at least one diagnosis of a mental health condition. 70% rise in the number of people in contact with mental health services over the last 8 years. The rise in diagnosis for children and young people is particularly acute. Currently, a fifth of children aged 8 to 16 have a probable mental disorder, up from 12.5% in 2017. And their analysis has forecast it will be 1/4 of all children by 2030 if the current trend persists. There are several studies now that are showing that people who get a diagnosis of ADHD in childhood, if you follow them up long term and compare them to a group who have similar behaviors according to these rating questionnaires but don't get a diagnosis, those who get a diagnosis are more likely to experience adversity such as poorer peer relationship problems and poorer self-concept. Very recently I met with a Norwegian professor. I've forgotten his full name, so I won't attempt it. But they've just finished a study using novel research techniques that are used in economics to try and establish causation. The principles behind it is that instead of doing a randomized control trial, because you can't do that for something like this, you look for what's called natural experiments. A natural experiment is when something changes in an environment while everything else stays the same. So you kind of have you develop a natural control group. And so what they looked at was they have 23 regions in Norway where they have CAMS services, child and adolescent mental health services, and they noticed that there was a 10-fold difference in the number of children who were getting diagnoses of ADHD. So they compared the areas where there were the lowest amount of ADHD diagnoses to the areas where there were the highest, and they have lots of public data that enable them to follow them up for an average of 10 years. And they concluded, and they're using this modeling system, that a diagnosis of ADHD causes, not just is associated with, but causes a greater likelihood of school failure, so dropping out from school, and poor performance at school, and a greater likelihood of ending up on a disability benefit. So there are important possible consequences of going down the route of diagnosis, not just the treatments, but the diagnosis itself. It shifts your self-concept, it shifts other people's concept of you, and not necessarily in a positive way. I've mentioned the school health awareness data. It's pretty bad. The study that I quoted recently is just the most recent. There's been studies using CBT principles, using mindfulness principles, using dialectical behavior therapy principles, and they all seem to suggest that if you attend these programs, you're more likely to be doing worse. You're more likely to be sensitizing people. So if psychiatric diagnoses aren't diagnoses, why do we have them so widespread? Why are more people being diagnosed with them? And why do we continue to use them? So my fourth assumption is that psychiatric diagnoses function as commercial brands, not medical discoveries. So we have created what I call a mental health industrial complex with a web, an ecosystem of products that spread out around these popular diagnoses. So you have the language of diagnoses, you've got medications, you've got certain therapies, courses, books, even toys, certain types of educational toys, research institutes, journals, magazines, influencers, podcasts. So there's a whole lot of money making that goes on. And social contagion is being turbocharged, particularly through vehicles like social media. Now, social media aren't the vehicles that created these concepts. I lay that at the door of certain branches of academic psychiatry, but they help spread these ideas so more and more people identify with them. And that has led to the rise of neurodiversity as well. And recently, in the service that I've recently retired from, our manager said now 80% of our cases are categorizable as being neurodivergent. So if you come to a CAMS service now in the UK, it seems that you are in a very small minority if you are not considered neurodivergent. And this leads me to also question then, what are the bases of the way we imagine humans to function in our society? Why is this something that seems so amenable to ending up in this picture? One thing that structures our economy, which will inevitably filter down into our day-to-day value system as to how we understand how we're meant to function and what's important, is what I call the compare and compete culture. This is a kind of hyper-individualism where we feel that we're in competition with those around us, and these affect our value system. It affects our model of understanding of how we function, of how relationships work, and it leads to a social atomization. And the sense that we're performing all the time in order to get value, in order to feel that we are offering something, we have to perform. We have to perform in all these different ways. And this creates all sorts of social status anxiety, leading to feelings of not fitting in, of not being good enough, of feeling judged. So this creates a lot of distress, and this is the distress that is now being turned into these brands. So the commodification of distress, it creates a mental health industrial complex. So we've got these twin things going on, a society in which we feel more and more insecure and pessimistic, and an industry that comes in and exploits that and turns it into a source of profiteering. There is also an aspect to psychiatry that has got very embedded in the concepts that developed in psychiatry long ago, embedded ideas of supremacy. Frantz Fanon is somebody who really explored this. He was a psychiatrist and psychoanalyst who actually ended up as part of the Algerian resistance. And he studied and wrote about, in two very well-known books, Black Skins, White Masks and The Wretched of the Earth, about the experience of how being a colonizer and a colonized affects your sense of self. And it really is something that's expandable to all sorts of different power differentials when one group have more power over another. So Fanon writes, the sense of inadequacy, insecurity in the colonized psyches results in violence, which can be seen as a form of self-assertion, an attempt to combat this sense of inadequacy. Natives are then compartmentalized and demonized. They are declared insensible to ethics. They represent not only the absence of values, but the negation of values. In this sense, they are required to represent the embodiment of evil for the colonizer. So these have effects on both the colonizer and the colonized, creating envy and hate and distrust. My final assumption is that as this hyper-individualism has developed, as mental health industrial complex has spread so wide, it's now merged in with identity politics. And it reflects a time in our society, in our economy, where there's a sense that things are decaying. So there's a crisis of economy, but also a crisis of legitimacy. We no longer, correctly I think, trust that our politicians know or are capable or even have the power to get us out of this sense that things no longer work and that things aren't looking like they're going to get any better. So identity politics and the mental health industrial complex kind of start to work in the same manner as a place that hoovers up this dissatisfaction, this emotional anger, and instead focuses on the rights of different minority groups. So people started identifying with their psychiatric diagnoses, particularly things like ADHD and autism, and they've entered into the arena of the culture wars. And the culture wars seems to be the area where modern left-right politics seems to fight around, and the traditional way of left and right, which tended to be around socio-economic issues and class war, seem to have disappeared. Margaret Thatcher once said her greatest achievement, when she was asked what was your greatest achievement, she said Tony Blair. And she was right, because after Ronald Reagan and Margaret Thatcher, the following premiers, and this kind of spread across most of the Western world, followed the same economic logic. So we are now living in a society and a culture that has these human typologies. We've got lots of different groups who create these small communities, and which is good. I mean, people need communities to come together. A lot of these communities around identities or around mental health labels, they tend to be online. But they also make it harder for this broader social solidarity that might be more likely to shift things at the structural level. So those are my assumptions. Those are the things that I found myself thinking about and trying to explore in my latest book. And just to try and maybe illustrate the power of the framework of understanding that you adopt, I will finish the story of Charlotte. So, if you recall, I'd been seeing Charlotte for 2 years, and she'd been with our service for much longer than that. Now, she was in another down period, and I was wondering what to say when she blurted out with an angry passion, "How can I get rid of this thing in my head?" Me. What thing? What do you mean? Charlotte. This depression. This whatever it is that I can't get rid of. Me. Can you say more? Well, there's obviously something wrong with me. A chemical imbalance, maybe some sort of brain problem, like a mental illness or something. Whatever it is, I can't shake it off. It struck me that I'd never really had a conversation with Charlotte, or indeed most of my patients, about what sort of theory or model they had about the nature of their problems. How stupid of me. This was many years ago, but most young people already had access to Google and of course were using it to try and make sense of the dilemmas they were experiencing. Me. What do you mean? There's nothing wrong with you. You're just reacting the way human beings were meant to react. There's no chemical imbalance, no brain problem. You have your better periods, and when you do, you've shown what an excellent, capable, imaginative, empathic brain you have. It works perfectly well. Charlotte goes quiet. She looks at the floor for a minute or so, her long auburn hair draped around her shoulders, partly going down her back, and partly either side of her bowed head. She looks up, somewhat quizzical. but surely there's something wrong in my brain. Something's not right. I feel it. Me. The feelings are real. They're powerful. They're distressing. I've seen how badly they affect you. But what if it's believing that there's something wrong in your brain, something wrong in your mind that is making it hard for you to be able to recover? What if the problem is that you believe the problem is in you? For the rest of that session and the following couple of sessions, we talked more about the power of the belief that there was something wrong in her brain or in her mind. We talked about the conversations she'd had with friends, what she'd heard on the media, and what she'd found on Google. The idea that there was nothing wrong in her seemed strange, so woven into her sense of self and identity had it become. She was both attached and simultaneously disparaging of whatever this was that she felt was a part of her. It seemed like she was in a perpetual battle, trying to suppress, ignore, control, and desperate to get rid of this part of her, but it just wouldn't go away. Maybe it was impossible to get rid of. Sometimes that felt okay, maybe even desirable. She had a reason why she couldn't manage to do what she wanted to do. It wasn't her fault. Other times she was so frustrated, despondent, or numb, overwhelmed when she thought about this thing, this mental health, this depression, this dysregulation that was always there. Even when she was feeling happier, having good days, it was lurking in the shadowland of her mind. She could never just enjoy herself or feel a sense of peace or contentment because it was there, always there, somewhere. Sooner or later, that shadow would swallow her up again. She was treatment resistant. Every time she hoped she was finally in recovery, back it would come. But she still hoped. Or did she? Which was the part of her that still hoped? Was it her unconscious that stopped her hoping? Or her conscious part that still hoped? Or maybe it was the other way around. Maybe it was this treatment, or the next one, or the one after that, that will finally slay the demon. But then, who would she be without this? The penny started to drop. The belief that there was something wrong in her had become the primary driver of her feeling so bad. It was how she felt about her feelings that made the original ones seem so awful, and that perpetuated the mutual belief, which at the time I shared, that getting better meant feeling better as opposed to changing how you feel about your feelings. This accords, albeit very loosely, with the psychoanalytic concept of internal objects and how we relate to our internal objects. Depression, mental illness, symptoms had become an internalized object, a part of her which she found threatening, dangerous, but also strangely alluring. The cultural stories we hear about depression, mental illness, symptoms, strengthen the boundaries, the presence, and the concreteness of that internal object. A collection of feelings gets tied into the object, and the power of this grows upon us. Charlotte's attachment to the belief in this inner mysterious entity that had kidnapped her began to melt. The next bad patch she had lasted 3 days. She resisted the idea of, oh no, here we go again. And she found after 3 days in bed she was ready to get up and get on with things. Something felt like it had changed. Depression, mental illness were no longer chains wrapped around her body wherever she went, whatever she did. Soon after, for the first time, Charlotte told me she was ready for discharge. And if there's one message in this book, it's really don't fear your emotions. We need to end this war on emotions that I'm afraid a lot of psychiatric and mental health ideology has created. And finally, back to the first saying that I put forward from Gramsci. The old world is dying. The new world struggles to be born. It will be born. So how are we doing the questions now? How's that? Oh, okay.
All right, I've got some questions here that have been coming in. Thank you, Dr. Timimi. Question one, what do you suggest as a solution for all children in the school system whose parents are being told to have their children evaluated for ADHD and other issues?
Yeah, that's a hard one because you can't blame parents for wanting to have such evaluations because this is the story, the narrative that we've been spreading. You can't blame teachers for that because they've also been caught up in this narrative. And at the same time, our schooling systems, if your schooling system is anything here like it is in the UK, are stretched and expected to do this, that, and the other, and it's become an arena where these performance metrics make it hard for a lot of kids. So we've got these fundamental problems in our schooling systems and in our public narratives. Still, I would recommend to parents, wherever they can, resist this temptation. And if you do find you have to go down that path because you need to access certain supports within the education system that would actually be helpful, and this can be a double-edged sword, then do hold that diagnosis lightly. Don't see it as a life sentence. Don't talk to the child as if it's a life sentence. It's just something maybe you needed to do to help them through the school system. Because one of the important things to bear in mind is one of the constants about growing up. In fact, it's one of the constants as we move throughout life, is change. And we do not want to put anything in the way of that will curtail the possibility of change happening. This is one thing I often talk to parents about and talk to young people about, is there's one thing I can predict with certainty about you. You will change. As you grow up, your body will change. The way you experience emotion will change. You'll start to develop abstract ways of thinking. Your music interests change. Sexuality will develop, etc., etc. Change is the one constant. Don't put anything in its way. Don't start talking about having lifelong conditions or you've got some sort of brain that means that you won't be able to do this, that, or the other. So if you need to go down this route, just be practical, but don't turn it into a potential accidentally disabling life sentence.
Okay, next question. Have we done more harm than good by destigmatizing mental illness?
Yes. Next question. No, we really have. Because what's happened, as I say, if we start destigmatizing something that we don't know what it is, one of my first things that I questioned was that when it comes to mental health, we literally don't know what we're talking about. So what are we destigmatizing? And what's happened instead is we've actually ended up sensitizing people to the idea that maybe they have this type of mental condition. And as I've tried to illustrate, actually when you internalize these ideas that your experiences somehow sit you outside of the social expectations or indicate that there's something serious going or potentially serious going on with you, especially with the types of stories that might spread around what it means to become mentally unwell, to become mentally ill, and with this idea that has also spread that we need to identify a problem early, because early intervention, so this is an idea taken from other parts of medicine. Early intervention is extremely important in cancer diagnoses or in trying to get on top of cardiovascular risk factors and so on. But it does the opposite in mental health. That's the way we create long-term patients. We create more problems by going down this route. And so destigmatization campaigns, they should all be suspended. They should all be suspended right now. What we need to do instead is be able to help develop a culture where we can talk about and get support for our distress without turning it into something we should panic about. We're all going to experience distress. We're all going to experience discomfort. We need to be able to talk about it without sort of shipping it off for professionals to deal with.
Okay, next question. Any tips for how to address this important topic with teachers who may carry unconscious stigma pertaining to a child's behavior in their classroom?
The issue with what's happened in a lot of schooling situations is that these concepts have spread within schools, and I mean, I can only talk about the experience in the UK. What's happened is in the UK in the last 5 to 10 years in particular, there's been a big expansion in the amount of services that are based in school, in these teaching of mental health awareness in schools. But there's also been an expansion in the number of teachers who are called pastoral support. And the pastoral support seems to be much more about identifying pupils who have a potential problem and getting them referred because of this kind of early intervention mindset. And to give you an example of how distorting that is, my daughter actually did a bit of research with some experienced teachers in secondary school, and this is one of the stories that sort of stood out from that research she did. This teacher recounted that there was a pupil who came into their form class. He was the form teacher, and he noticed this pupil was distressed. And so he just went to ask him, "Are you okay? Do you want to talk about it?" Anyway, this kid wanted to talk, and the teacher chatted to him for a bit, and after they chatted, he seemed to be a bit better, and he came back the next day and the day after, and he just asked him for a few days, "Are you okay? Do you need anything?" And the kid seemed okay. When he spoke to one of the pastoral support people, who was like the manager of this pastoral support program, she told him off. She said, "You shouldn't have done that, because how do you know that he wasn't developing a mental health problem? You're not a professional, and you might have, because you don't know the right way to talk about things like that might be a mental health problem, you might have made it worse." So this kind of ordinary thing, it's a very vivid example of how ordinary responses to ordinary experiences get put into this bracket of something potentially dangerous. So we really need to help teachers out of that mindset, and in the ideal world, we'd be able to provide some training that destigmatizes teachers from stigmatizing with psychiatric labels. It's not their fault. I mean, this is what we're teaching.
Next question. How can we ensure that in shifting away from labels, we can still provide real access and support to those who do need structured care, including in marginalized and underserved communities?
The thing that would make probably the most important differences to marginalized and underserved communities is for our politicians and our economic systems to be fairer. So to deal with things like poor housing, high rents, insecure jobs, unemployment. And if we want to take mental health seriously, then we need to look at these social drivers of distress and insecurity. And so my starting point would be that this is something that we need to focus on to start with, is to be able to put whatever pressure on our politicians, and to be aware that a lot of mental distress comes down from economic drivers. But when it comes to mental health services, well, we do already have quite a few models. The World Health Organization published a guide on example systems, and they included 28 different approaches that they considered to be model approaches. The things that they had all in common is that they focused away from psychiatric diagnosis and away from medicalized pathways. They focused on rights and social approaches and supports of that type. So examples include things like the open dialogue system. This is a kind of a narrative therapy type of approach. In other words, you're approaching people's experiences as meaningful. There's a model that developed for quite a long time in Italy, certainly in parts of Italy. It started with a movement called the democratic psychiatry movement by a very influential psychiatrist called Franco Basaglia, who started that movement, and it eventually led to a change in the law in Italy, which ended up closing down the hospitals, the psychiatric hospitals. They were the public psychiatric hospitals were nearly all closed, apart from a few. And all the services were moved to the community. And the services there are community-based. They work with the different parts. They work with housing. They set up social enterprises, so people who are service users run services, bed and breakfasts, bicycle repair shops. So they also have this practical nature. They provide that type of guidance, as well as therapeutic support. And they have the lowest rate by far in Europe of people who end up with a compulsory admission. So in this area in Trieste, the law is that you can only be admitted against your will for a maximum of 7 days, which is renewable for a maximum of another 7 days, and only for treatment. It has nothing to do with risk. You can't use risk as a criteria. And they have a lot of success. Their first session when they meet is not called an assessment. It's called the engagement session. So it's a very humane as well, very relational centered. There are lots of different ways you can approach this. And the thing that we need to have is to shift from this idea that we think about how to categorize internally, and that our assessments are about getting the right category right, to deliver the right intervention, and to think contextually and relationally. Those are the two things anyway in the psychotherapy outcome research. Those are the two things that have the biggest influence on outcome anyway.
Okay, next question. We hear again and again from people like the Australian journalist you cited, who said how comforted she felt to getting a diagnosis of ADHD. And we hear from young people in Ritalin who feel at last they are able to focus, or young people diagnosed with anxiety who feel they can cope better on anti-anxiety drugs. What is wrong with having a diagnosis or receiving a treatment if it makes the person's life better?
So I think I've been presenting a lot of evidence that might be how people feel, and I understand that. But the evidence at the population level tells us that the opposite is happening. People are not recovering in the way. Anybody who's worked in psychiatric outpatients will see that picture of people coming and coming again and again. There is a number of risks. I understand that people feel that they've had this kind of liberatory moment, it's a strange shift in the way psychiatry functions. Psychiatric label as functions, as I said, is sort of merged into this identity politics space. But one of the things that can start to happen, because these are commodities, because you actually haven't had an explanation, most commodities tend to have a limited shelf life. So what you often find is that experience that, oh, I feel so much better now, I understand what's going on, that is going to help me get through it, and that's going to help me be able to function, is actually accidentally you can start doing a number of things. Firstly, you can start limiting yourself from doing things that you might be capable of doing. So you might disempower yourself accidentally. Another thing that can happen is that this particular label that felt liberating, after a while, doesn't seem to quite do it enough. And this is what happens with commodities. Commodities tend to be great to start with, but they're almost made sometimes to have a limited shelf life. So you start thinking, actually, maybe there's another diagnosis or another intervention, and you can start down the route of collecting more diagnoses and collecting more interventions, be they therapy, be they medications, etc., etc. Meanwhile, you're eating away at being able to understand your own resilience. So tragically, I've seen young people, 16, 17-year-olds, who are coming to the service, and they've already collected several labels. I saw a young person not that long ago who came to our clinic. She'd been diagnosed with autism, ADHD, PTSD, an anxiety disorder, panic disorder. She thought she had a dissociative identity disorder, but now they were coming to the clinic because there's something else going on. There's something deeper. Now they're wondering if she has a bipolar disorder. And this is the sort of picture that you can start to see happening. And that's what's reflected in the data that I was sharing with you. More and more diagnoses, more and more treatments, more and more services, more and more people getting worse outcomes.
All right, we have 2 questions left. How can communities and grassroots organizations play a stronger role in creating spaces for healing that don't rely solely on diagnosis or medication?
So how can you go about, what was the start of the question?
Yeah, I'll just repeat it. How can communities and grassroots organizations play a stronger role in creating spaces for healing that don't rely solely on diagnosis or medication?
I think there are actually an increasing number of people out there who are doing this. They're partly online. I suspect AMI are involved in trying to help people to do this. I can't lecture people on how to go about organizing, but I think they should, and I think they do. I suspect that's already something that, and there is something very useful for people who are coming together to try and empower themselves, and there's something very powerful about people meeting together and being able to talk. And one of the sayings that I often that I've had many trainees over the years of all different is I've talked to people about how stories of suffering are also stories of survival. One of the things that we need to do with suffering is we need to be able to be witnesses, we need to validate, people need to tell their stories, need to be heard. But also we need to notice the capacity that people have. People do survive. I've been continuously amazed and reassured and humbled by the capacity of the human spirit to be resilient, to find recovery. I've seen people who've been so functionally impaired for years and years, and they find a way out, and they make it to recovery. There's a lot of positive energy and storytelling for how to survive and how to get through, whether it's online communities or even better in-person communities. And I just encourage people to do that, and you will find most people have something in them that can help them keep going and can help them get out of even the deepest hole.
And the last question, what was the title of the book you read from that included the story about Charlotte?
It's the full title, it's this book here, Searching for Normal, A New Approach to Understanding Mental Health, Distress, and Neurodiversity. Okay.
Thank you so much, Dr. Timimi. I think that you leave us with lots of food for thought. I hope that it stimulated your appetite, because this is really just a teaser. And as someone who did read your recent book, I think that as disturbing as it is, and it is disturbing, it's a must read. So thank you. Thank you very much. And the books are available for sale at the reception. Thank you very much for attending. I just want to remind you again to please do visit our website, update yourself with our programs, and don't hesitate to call us or to email us if you need any help. Thank you, and see you next time.